The partial pressure of oxygen, or PaO₂, is a critical component of arterial blood gas, or ABG analysis, providing information about how well the lungs are doing with respect to oxygenation. The standard international unit for partial pressure is kilopascals, but in clinical practice, millimeters of mercury is more commonly used. To convert between the two, remember that 1 millimeter of mercury equals 0.133 kilopascal. To go from millimeter of mercury to kilopascal, multiply by 0.133. And to go from kilopascal to millimeter of mercury, divide by 0.133. In this Medmastery course, we'll stick with millimeters of mercury, but knowing this conversion is helpful since you'll encounter both units in different contexts. Normal PaO₂ levels typically range between 75 and 100 millimeter of mercury when breathing room air at sea level. Deviations from this range can indicate respiratory disorders, lung diseases, or that oxygen therapy is not sufficiently improving oxygenation as expected. Studies have shown that supplemental long-term oxygen for more than 15 hours per day in patients with severe resting hypoxemia increases survival. On the other hand, oxygen does not benefit patients with stable COPD experiencing slightly lower than normal arterial oxygen levels, partly due to their adaptation to mild hypoxia and a diminished respiratory drive with supplemental oxygen. Long-term oxygen supplementation is needed in patients with a PaO₂ less than 55 millimeters of mercury, or an oxygen saturation below 88%. And if their condition is complicated with pulmonary hypertension or congestive heart failure, the magic number is a PaO₂ below 60 millimeters of mercury. These patients should have their ABG tested at least twice over a 3-week period to confirm that the levels are low enough for oxygen therapy. After starting long-term oxygen, your patient should be reevaluated in 2 months with a repeat ABG test or oxygen saturation measurements using pulse oximetry. This evaluation should be conducted while the patient is breathing room air or at the prescribed oxygen flow rate. The results of this reevaluation will help you decide if the patient still needs to be on oxygen or whether an adjustment to the flow rate is needed. The goal of oxygen supplementation is to keep oxygen saturations of the blood above 90%. An important consideration is that some pulse oximetry machines falsely overstate the blood oxygen in patients with darker skin pigments. For this reason, in patients with darker skin, an ABG may provide a more accurate measurement of oxygen saturation compared to pulse oximetry. Now, if your patient is planning to travel by air, temporary oxygen therapy may be needed because of the decreased partial pressure of oxygen at altitude. Patients with resting oxygen saturations more than 95% and a 6-minute walk oxygen saturation greater than 84% will likely not need supplemental oxygen on an airplane. But patients with moderate to severe hypoxemia at sea level will need supplemental oxygen during air travel at 3 liters per minute by nasal cannula.
So I hope you liked this video. Absolutely make sure to check out the course this video was taken from and to register for a free trial account which will give you access to selected chapters of the course. If you want to learn how Medmastery can help you become a great clinician, make sure to watch the About Medmastery video. So thanks for watching, and I hope to see you again soon.